Good afternoon. And,
Hi.
and today we have a pleasure of interviewing my friend over 20 years, Dr. Inna Gellerman. Good afternoon, Inna.
Hi, how are you?
And again, thank you to our audience. If you have trouble sleeping or sleep next to the snoring partner, please click the like and share button. This way you can spread word about our channel. And if you are a medical professional who are helping patients to sleep and breathe better, please use uh, our channel as a networking ground. This way together we can put all the puzzles together of this multifaceted disease and uh, bring well-deserved health to our patients. And let me tell you, I'm very honored to introduce Dr. Inna Gellerman because I actually witnessed her hard work in getting to this highest professional level where she is right now. She graduated from Stony Brook Dental School and Stony Brook Orthodontic Residency, and she did multiple research and she lectured. And she's been practicing orthodontist for more than 20 years, but this year is very special. This year we celebrate 20 years of private practice what Dr. Gellerman founded. And I was actually witnessed that moment 20 years ago, and I'm very honored to be such a long-standing friend. So thank you for your friendship and inspiration, because Dr. Gellerman, she practiced orthodontics in our practice in Harmony Dental Arts as well, and she successfully treat a lot of our patients. And after that many years, she is not practicing. I still see those successful cases what Dr. Gellerman treated. So thank you for that. And today we're gonna find out from Dr. Gellerman, based on her more than 20 years of clinical experience, a lot of hard questions related to orthodontics and sleep. So my first question to you, doctor, what would be when patient choosing orthodontist for themselves or for their child, what factors they consider to make informed decision to ensure that best possible treatment outcome?
Well, thank you, Dr. Sakalina, for such a kind introduction. It is 20 years since I opened my own practice, and I don't know where did the time go. It felt like it was yesterday, but 20 years flew by. So I think in the beginning, 20 years ago, things were simple. You come in, you have crooked teeth, we could straighten it, done. And I think over time, I learned that teeth are, attached to the rest of our body. And we can't just look at teeth separately. When we go to our physician, at this point, I want them to spend more than 10 minutes with me, and I want them to, evaluate my whole body, my whole health. And not just, to say, oh, okay, you're doing great, no fever, nothing, goodbye. So I call it integrative orthodontics. So when the patient come in, it's an hour of an exam allocated to them. We take pictures, we take x-rays. They have to fill out some questionnaires. And then I sit down and I ask them questions. Some of the questions specifically to what I see on the records. And some of them are just general questions. A lot of times we see kids and adults, and a lot of times the family come with the siblings. And the first question is when I ask them, how is your sleep? Like, do you snore at night? Do you sleep? Like, are you a restful sleeper? Then I ask the parent, and the parent's like, well, I really don't know. I think he sleeps fine. And then the sibling will jump up and say, oh my God, he snores all night long. And I think the parent is shocked. Just, it's the first time they hear that. They had no idea. They sleep in a separate bedroom. There was a couple of times when the parents came in and they said, I had to move this appointment, like you have to see me immediately. What happened? They went on vacation, they all slept in the same room. The parents couldn't sleep because the kid was snoring, and they said, what is wrong with the child? Like please help us, what's going on? So it is, it's a question that I think everybody should ask. It's a very important question. And sometimes it's just being missed. But that's just one of them. The other question I see, where's the tongue position in the pictures? And then I ask the kid move the tongue and just do like a couple of different like tongue swallowing exercises to see if the tongue is functioning properly. And if not, I would, recommend them to go see the myofunctional therapist. If there's a tongue tie, I would recommend them to see a specialist to laser it off, or at least to talk to them about the benefits of lasering it off versus leaving it intact like that. I asked them about other habits. I asked the parents about how the kid drinking water, eating food. Is that too loud? Do they think, some parents come in and they say, my kid, like they don't pick food, like they like all kind of food, but they can't swallow it. They sit with a bowl of food in their mouth for like hours before they're able to swallow it. Well, it's not because it's a picky eater or anything. It's just, it's hard for them to properly position the tongue and swallow the food. And we have a myofunctional therapist in the area that deals specifically with that issue. So all of those questions are important because when we propose our treatment, in some cases it would be a palate expander. I want to coordinate properly with this specialist as well. Who comes in first? Who does think first? Who does think second? That everything goes smoothly from start to finish, and the kid can benefit from it tremendously, and therefore the family can benefit as well. And I think the other thing with the kids also is the posture. It's super important. Sometimes I see the kids and they sit in like this, like sideways. And I'm like, oh, is that always? They're like, oh my God, we go to physical therapy. This is just how my child posture. We're doing so many exercises. And then I ask them to leave the tongue, and the tongue has like a tongue tie that's this short. So as soon as they get their tongue tie removed and they do a proper myofunctional therapy, their posture starts to improve on its own. I follow a couple of chiropractor accounts on Instagram, and some of them, at least once a week, they post something about the tongue posture, the tongue function, and how important it is for the rest of the body posture. And I think we just have to keep it in mind. So, it is important for us as an orthodontist to give a proper, full answer and provide the full diagnosis to the patient. It's not just about teeth.
No, that's wonderful. I really like how comprehensively you look. And what's extremely pleasant for me to see how your philosophy developed over years. So basically, we go in a parallel routes, and we kind of, I would say, our vision got better with the time. So we see more because we start looking at the teeth, and then our knowledge develop, and we see the results, and we can make a connection between observations. I think it's wonderful. And I want to mention, I didn't mention it in the introduction, and I want to bring a special attention what Dr. Gellerman, she was one of the founders of PANI, called Pediatric and Adult Airway Network of New York. That's a very unique organization. She founded with Dr. Stephen Lambert, who we interview on our channel as well. And I think it's a organization what has the similar mission to our channel. It's connect medical and dental community, not just the doctors, but also myofunctional therapists, dental hygienists, sleep technicians, people who related to the sleep and breathing areas. And we have our beautiful conference once a year. And in general, just to be member of that organization and such an honor. And it's thank you again for making it happen. I know it's a lot of work into organizations part of that as well. And I would like to ask you a very hot question. And the reason it's hot, because I see the result of it in my sleep practice. It's related to extraction of 4 bicuspids. And could you explain if this is acceptable treatment option, and address about potential concern regarding the small mouth in the future? Because in my practice, I see those patients who come with the sleep and breathing and snoring and, a lot of other problems. One of the things I asked them if they had a previous orthodontic treatment, and a lot of them did. So please tell me your opinion and how it shaped, your philosophy over the years from orthodontic training to present time.
When I went through my residency, there was like two camps: extraction, non-extraction, and they were, kind of like arguing between each other. But we probably had about 50 cases. 50% of cases could go non-extraction, and 50% of cases, if in doubt, we took teeth out. I think when I started my practice, I probably were like 30 to 40% still extraction. And then as my knowledge developed, as I saw more adult patients come in, and just like you mentioned, they come in and they had treatment in the past years ago, and 4 bicuspids were removed, and they come to my practice and I take the pictures, and the amount of crowding is enormous. And at this point, there's nothing to remove anymore. Their jaws and the teeth are collapsed inwards. Teeth are all over the place. And they said it didn't happen overnight. It happened over years. But they said, I just don't understand. My 4 bicuspids were removed. My wisdom teeth were removed. Why is it still happening? Well, the teeth are moving all our life. If we never had treatment, they're going to move. If we had treatment, they're going to move. It's a normal process. Our hair changes, our skin changes, elasticity of the fibers changes. Everything's changing inside the mouth as well. So we should expect that constant change. And as we age, everything's changing, not in the best direction. Let's just put it this way. So yes, everything constricts. It's not a perfect, beautiful picture. So what we do in those cases, we move teeth back to where they were. We try to upright the teeth, upright, and expand the arches and move everything back in their places. There's nothing more to extract. All the teeth that were extracted were already out. So if we could do that, that kind of gave me an idea. Then why don't we try to do non-extraction in the cases where the amount of crowding is excessive? And what are the options? So I, have different appliances that I work with over years, and it works great in my hands. And it also works great if the patient is cooperative and they wear the appliance properly, and they will wear the rubber bands with it properly. And we were able to save 4 bicuspids and come, finish with the beautiful results, not super proclined teeth, not unstable results. And maybe we'll take wisdom teeth out in some cases instead. In some cases, we don't even have to take wisdom teeth out. So there are other options to prevent the jaw getting smaller and collapsing. And I think we as an orthodontist, I think we have to always evolve and try different things.
I really like how beautifully you put it. If you can name a couple appliances for, if other orthodontists listening to us, maybe they can pick up that wisdom, what appliances you work to prevent that from happening?
So I have a pretty good success with Invisalign in terms of distalization and, creating room for teeth to erupt and creating room, preventing the extraction. I also work with Invisalign, and we take wisdom teeth out sometimes, and also utilizing the space even within the bottom arch to distalize, and that works as well. I like Herbst appliance, and I had some success distalizing with that, and I've had some success correcting class 2 overbite, overjet malocclusions without taking first bicuspids out on the top. So I think, the appliances are out there. It's just a matter of trying, see what works, see what doesn't work, what kind of cases it works with, what kind of cases are doomed and have to have teeth removed. I mean, there's a learning curve to it, but I think it's very doable.
And I'm going to ask you another kind of hot question now, especially for orthodontics and sleep community after the article of Dr. Andrea Yun. A lot of people discussing. I would like to know your perspective on phase 1 orthodontic treatment. Do you believe in the importance of it in overall care, and what do you use to accomplish phase 1?
So when I went through my postgraduate orthodontic training, we were trained in phase 1 and phase 2. So when I graduated, I was very comfortable breaking treatment in 2 phases. And I think I was kind of like had a pretty good, clear checklist of who falls under phase 1 and who we should wait for phase 2 or full phase to start. So phase 1, we treat them. I personally start treating them when they have their 6-year-old molars in place and when they have their upper incisors, 2 upper incisors in place. It's palatal expansion, somebody who has a skeletal maxillary constriction, high, deep vaulted upper jaw, habit, thumb sucking habit, um, constriction of the upper jaw, and change in the position of the lower jaw, and the lower jaw now being asymmetric. So those 3 cases definitely fall under phase 1. Space loss, like premature loss of baby teeth and just regaining the space, regaining the symmetry, and anterior crossbites. So those are the cases that I'm very comfortable to treat in phase 1, and I think they needed to be treated in phase 1 because you set their foundation for the future.
Very good words.
You create the space, and then they can wait until the rest of their adult teeth will come in. And if they like how they come in, they don't need to do anything. If they come in crooked, we can line up the teeth, but we have room for the teeth and we have a proper foundation for the teeth. If they have sleep issues, if they have eating issues, if the tongue position is improper, if the upper jaw needs expansion, those are the cases that are really like phase 1 cases. And I think it's unfortunate that sometimes they come to us and they're 12-year-old and they would say, well, we were waiting for more adult teeth to come in. The dentist said, well, it's too early, and we were waiting. I mean, they can still be treated, but you just can't get the same expansion as you can on a 7-year-old. So it gets a little bit tricky.
I really like how you put it in our conversation, what the child have to be checked by orthodontist by age 7. And doesn't matter baby teeth, not baby teeth, baby teeth, obviously in age 7, but I think it set the foundation for health, especially if orthodontist is considering other things like habits, eating style, posture, sleeping.
It's one appointment. If they don't need anything, I don't have to see them until I see them once a year, making sure they lose their teeth properly, symmetrically, and there is no other issues. But if they need it, this is the time to do it. This is like the best time to do it.
I would like to ask you, you were one of the first people in the country, which make me very proud to be, to know you. I remember the time when you get your 3D X-ray. And I remember visiting you and I was like mesmerized by the technology. So you are the one who worked with 3D X-ray for many years. And tell me, and we have it also now based on your inspiration, and tell us how this technology changed your perspective on diagnosis and treatment planning in orthodontics. And I want to make sure our audience, when they choosing the orthodontist, they take this answer into the consideration.
So I'm on my second iCat 3D cone beam machine. I have iCat, and my first machine was 2006. I think nobody knew what it was at that time, but I had some experience from my previous job. So I was renovating the office, and I said, it's either now or never. So I had it, and I worked closely with the radiology, and over time learn a lot of things to read myself, but we do send the scans to the radiologist to be read. It is very helpful. I find it that it's number one, just at a first glance, to see what is the skeletal structures like. Do you have skeletal constriction? Do you have skeletal asymmetry? Do you have skeletal underbite, overbite? Impactions. Easy to localize where the tooth is impacted. When you send to the oral surgery, I send them a few of the x-rays pictures, and it's an easier procedure than for them taking 5 different x-rays to figure out is the tooth position labially or lingually. We found a lot of supernumerary teeth that I couldn't see on the panoramic x-ray. I had some cases come in and they say, oh, my dentist have an x-ray, they send it, or I saw somebody else and I have the panoramic x-ray. And you see a shadow, but you're really not sure what that is. And then, when you take your 3D and you say, well, here we go, we have an extra tooth. Nobody ever mentioned it to them. They had no idea. So those things that definitely make my life easier. We had lately a lot of, and I think over years, we see about 40 to 50% adults in the practice. So a lot of them come in with TMJ issues. And lately, it's just a lot of TMJ cases. At least once a day, we have a patient that would come in and say, you know what, everything was okay. It wasn't fine, but it was okay. And then 6 months ago, I started developing pain on one side with the TMJ, in pain constantly, like what's going on. And TMJ is, it's a big subject. Is it a joint? Is it the muscle? Is it some actual issues with the anatomy of the joint, or any like changes within the joint? Do they need the surgery? Do they need a night guard? Or it's simply muscular? It has nothing to do with the joint. Or it could be occlusal, that, the way their bite is, that, once you line it up, it will help. So I think the 3D and the radiologist, we diagnose so many like degenerative joint disease and some other issues that I don't think I would have seen on a regular panoramic x-ray.
No, that's great. I like what you take such a comprehensive view on a patient treatment, not only from the history point, but also from inside. My last question to you, and I know that's been also new step in a sleep orthodontic intervention, I would say, or collaboration. When you consider expansion for adults, and we both know how those adults look like, with the palate very narrow and TMJ issues as well, do you recommend them to have a sleep study done prior the orthodontic treatment? And what relationship you see as a practicing and highly knowledgeable orthodontist on a relationship between expansion and sleep related issues?
So we have a lot of adults, when they come to us, they already come in because they were diagnosed with sleep apnea, and their medical professional told them either, listen, you can get a CPAP or you can get a dental appliance, and they come for that. Then you evaluate their jaw and you say you have constriction of the upper jaw, high vaulted palate. It could be that if the obstruction is in that area, it would be nice to expand it, but at this point, you need the surgical expansion. A lot of times they say, yes, I was told before I need an expander, I never did that, or I was told before I needed surgery and I never did that. Some of them proceed with the surgery and have a great outcome. For some of them on the younger side, there are other options like MARPI. It's kind of like a combination of surgery, but you don't have to go to operating room to be fully intubated. And the orthodontics, just, somewhere in between. And we have had pretty good results with that also. And some people just say, listen, I'm okay. I don't want a CPAP, but I want a sleep appliance. Can we start with that? Let me see the improvement, and then I can decide if I want to change my jaw or just, live my life with a sleep appliance. And that's an option also.
Well, thank you very much. We really appreciate all this, knowledge, and we wish you a lot of success in your pathway of putting together sleep and orthodontics and establishing a good health for younger generation. And we are very passionate about that as well. So thank you.
Thank you. Thank you for providing that opportunity for me to